Hi, I'm here at ASCO 2019 where I just had the opportunity to discuss in an educational session the treatment of upfront treatment for multiple myeloma based on disease risk stratification. So basically in that setting we have made progress over time. So the first piece that I think is important is that we are better able to stratify patients based on their disease risk. So we have different risk factors that are both based on genetic abnormalities or alterations, but also on patients themselves. So patients who are frail or have other comorbidities are higher risk. And what we mean when we say higher risk is that they live less long than patients who don't have high risk features. So when we discuss an optimal induction therapy for these patients, it's important to know where they fall in this risk stratification because we have better treatments available and we're better able to tailor our treatments for our patients. So essentially we know that triplet induction regimens are standard of care for our patients, whether they're transplant eligible or ineligible, with some of our ineligible patients having a harder time tolerating all three drugs, but when it's possible, we like to give them. Usually those treatments involve a proteasome inhibitor plus an immunomodulator and a steroid. But what we're learning over time and what is coming out at meetings like this is that while the current standard of care is triplet therapies, the field is moving often towards the incorporation of monoclonal antibodies, and that's going to change how we do disease inductions. So that data is still coming, but is one of the exciting things that we have the opportunity to hear about here at ASCO this week. In terms of transplant, it's usually, we still believe that transplant is standard of care for most patients after their induction therapy, but we're also learning that minimal residual disease detection plays an increasing role in the way we treat our patients, and it might be that over time we have the ability to stratify patients not just based on their disease risk, but also based on their responses. So that if patients are truly MRD negative, do we really have to do a transplant still? Can we change their maintenance strategies? So all of that is data that's still pending. So the current for right now is still that patients who are eligible should get an upfront transplant. But again, that's changing. Then in the maintenance setting, we recommend maintenance for most patients because there's been an overall survival advantage demonstrated for patients who get at least lenalidomide maintenance versus placebo. But the data for high-risk patients has been slower to come out. So probably patients who have a higher risk disease need a little bit more than just lenalidomide maintenance alone, whether that's a combination with a proteasome inhibitor or a proteasome inhibitor. So essentially the state of the state in induction therapies for myeloma is that triplet regimens are still standard of care inductions, but we're better learning how to pick our partners in terms of a proteasome inhibitor, with some of our newest trials showing really high rates of MRD negativity, and that correlates with better outcome. So there's a lot of data being presented here at ASCO, and we have a lot to learn still, but the bar is moving. Our patients are living longer, and I think that's the message that I try to bring home to my patients, is that whether you're standard or high risk, your outcomes will be better. You're going to see more therapies than we've ever had before, and the future is bright.